post-spine surgery. Ms. Liu Miao will talk on perioperative nursing experience of spinal tumor. And our session chairs for today will be Prof. Yusuke Nishimura and Prof. Naya Krishna. Our commentators will be Prof. James Wang and Dr. Liu Boon Singh. So without further ado, may I call upon Professor Yoko Kato to give the opening remarks, please.
Okay, thank you very much for everyone. I think today's webinar, the focus on the spinal surgery, especially the Yamamoto sensei and Nishimura sensei is very, very expert, especially minimally invasive focus thing. So, and also the nurse team is also the very expert, the nursing care of the spinal surgery. So we will have a very fruitful webinar, and also the commentator is come from the China, the first one, and Dr. Liu. So I think we can start our webinar. Very much looking forward. Okay.
Okay. Without further ado, may I invite Professor Yusuke to chair the first session.
Okay, can I start?
Yes.
Yeah.
Please.
So
Yes,
okay.
please.
So hello everyone. My name is Yusuke Nishimura from Department of Neurosurgery and in Nagoya University, and I'm also working as a director and chief of spine team and director of spine Nagoya Spinal Program. So today we welcome Dr. Yu Yamamoto. He's chairman of Inazuma Municipal Hospital, which is a very big, one of big affiliated hospitals in Nagoya University. And he's also actively working as a board member and faculty member of Japanese Neurosurgical Society and the Neurospinal Society of Japan. And today's topic is about minimally invasive spinal surgery. And he's a very skilled spinal surgeon, and he specializes in minimally invasive spinal surgery. So I'm looking forward to hearing today's presentation. And please start, Dr. Yamamoto, please start your presentation.
Thank you for inviting me. Let's talk about the minimally invasive spine surgery. So can you hear me? Is it okay?
Yes, we can.
Okay, let's start. Hello everyone. My name is Yu Yamamoto, a neurosurgeon at Inazuma City Hospital. First, I would like to express my gratitude to Professor Yoko Kato for giving me the opportunity to speak today. I understand that the most of the audience here are nurses. I hope that my talk will align with the goal of this event and that it will be helpful in your daily medical practice. Here is today's outline. It is impossible to cover all aspects of MIS, so I will introduce a few select examples. First, what is minimally invasive spine surgery? MIS. MIS is a term used to describe surgeries that involves less physical invasion compared to standard open surgery. There is no clear definition of MIS. This type of surgery uses smaller skin incisions and specific equipment, which usually causes less damage to muscles and other tissues. As a result, patients tend to experience less pain and recover faster. What conditions are indicated for MIS? Although many diseases and surgeries can now be performed using MIS, the need for specialized equipment, surgical tools, and the surgeon's skill means that not all hospitals can offer these procedures. However, the inability to perform MIS is not necessarily a disadvantage, and postoperative outcomes are often similar. Additionally, MIS may be less cost-effective in terms of healthcare economics in some cases. Here is a list of common surgeries. For herniated disc, there are endoscopic procedures such as MAD and pelvis. For spinal stenosis or spondylolisthesis, there are endoscopic decompression surgeries and minimally invasive relief �МIT. For spinal deformities, lateral interval diffusion (LIF) is available. For spine trauma, spinal fixation surgery or pachythermal spherical screw PPS is available. And vertebral fracture, 𝑑𝒓𝒐𝒇 is available. MIS needs some special devices and instruments. First, a retractor is needed for a small incision. Imaging systems such as fluoroscopy, navigation system, or intraoperative CT scans are often used to visualize areas that cannot be seen directly. While our hospital does not have one, there are surgical robots specialized for spinal surgery. Here is the list of the advantages compared to open surgery. There are smaller scars, less tissue damages, and this is be better for less post-operative deformities and leads to higher patient satisfaction. And next is less bleeding, less pain, faster recovery, less infection, and less screw malposition. Next, the disadvantages include neurological deficit, and this is similar or slightly more frequent, but permanent deficit are the same. Cerebrospinal fluid leak, hematoma, this is more frequent in MIS, may require reoperation, increased radiation exposure, technical difficulty, and cost. High cost due to the necessary equipment and surgical tools. And I would like to explain the role of nurses while presenting a few actual surgeries. This time, I will introduce 3 types of surgeries. I will not be able to explain everything in detail, so I will focus only on the key points, highlighting the differences between open surgeries and MIS. First is BES, and next is mini open PLIF and LIF. The basic process in MIS. In general, the same preparation for general anesthesia as in open surgery is followed. Although it depends on the type of MIS, most are performed under general anesthesia. Some endoscopic MIS procedures are performed in the local anterior. We use checklists and clinical pathways to standardize procedures. They are not specially designed for MIS, but are created for general anterior and spinal surgeries. Regarding BES, as the term bipolar suggests, it is an endoscopic surgery that uses two ports. As shown in this video, one port is used for endoscope and the other is for surgical instrument. A notable feature of BES is that instrument used in standard open surgery can be used through the working ports, and the operation are completely independent of the endoscope, allowing for free handling of instruments. We perform these surgeries under general anterior, although this is not limited to endoscopic surgeries. Taking a medical history and reviewing symptoms is important. Endoscopic surgery is one of the procedures with a high risk of wrong level surgery, since endoscopic surgeries involves smaller skin incisions, limited visuality, and are often performed by a single surgeon. Therefore, nurses are also asked to confirm the patient's symptoms and ensure the surgery site is correct. Due to the limited field of view, unintended nerve damage can occur, so nerve monitoring is essential. Therefore, it is necessary to collaborate with the anesthesiologist regarding anesthesia methods and the use of muscle relaxant. MAP monitoring and electromyography are commonly used. In this video, you can see that one of the advantages of endoscope surgery is that everyone in the operating room can share the same surgical field view. The nurse stands beside the surgeon and hands over the instruments. Although endoscopic surgery often requires specialized tools different from those used in open surgery, in the case of BES, we can use the same instrument as in open surgery. Attention must be paid to the appearance of neurological symptoms due to postoperative hematomas. This is one of the most concerning complications in endoscopic surgery. Due to smaller skin incisions and less tissue invasion, the space around the nerve is limited. Even a small amount of postoperative hematoma can easily lead to nerve compression. Monitoring the drain is crucial. The patient wears an external brace for local immobility and undergoes rehabilitation. Although early discharge is possible, we typically keep patients hospitalized for about a week to prevent postoperative hematomas. Next is minimally invasive PLIF, MI PLIF. Compared to open PLIF, this procedure is performed through smaller incisions. We use percutaneous pedicle screw (PPS) insertion for this procedure. Through the central incision, we perform nerve decompression and insertion the cage. This is the video. The necessary preparation for 𝑚𝒂𝒃 are in place, including an X-ray protector. This is intraoperative CT, that is OR, navigation system, and also we use fluoroscopy and microscope and radiation resolution bed frame and neuromonitoring. Many of the surgical tables have an open design on the patient's abdominal side, which can lead to heat loss. To prevent a drop in body temperature, we cover the abdomen with a plastic sheet. This is what the scene looks like just before the surgery begins. In MRS, radiation devices are frequently used. Take measures to protect against radiation exposure. The nerve decompression has been completed. The cage is inserted outside of dural sac. We use a distractor to gradually expand the intervertebral space while confirming the position with fluoroscopy. The video skips forward, and now we are inserting the pedicle screws. The nurse is preparing the screws, but care is taken not to touch the part of pedicle screw that remains inside the body. This is important. We are using navigation system based on intraoperative CT images to guide the screw insertion. This is patient the day after the surgery. When performed as MIS, even in fixation surgeries, patients can get out of bed on their own the day after surgery. By the next morning, patients are assisted to get out of the bed under the supervision of nurses. Of course, we need to be cautious about the risk of pulmonary embolism due to DVT, especially in patients who had preoperative paralysis in plantar flexion of the ankle, as they are at higher risk. For this reason, it is essential to confirm symptoms before surgery. Some patients with severe spinal stenosis already have urinary dysfunction before surgery. After removing the urinary catheter, it is important to closely monitor their urination status. This is a different case. It shows the scene where PPS is being inserted. As I mentioned earlier, we set the implant without directly touching the screw part.
はい、6点が40。
Next is lateral interval fusion, LIF, which includes techniques such as X-leaf and O-leaf. This approach accesses the vertebral body through the lateral abdominal wall to perform interbody fusion. By using specialized neuromonitoring devices and retractors, the fusion can be performed in a manner that closely resembles a percutaneous approach. Since the procedure passes through the retroperitoneal fat, it results in minimal invasion to the body. Check for a history of retroperitoneal surgery. Since the procedure passes through the retroperitoneum, patients with a history of retroperitoneal surgery are not candidates for LIF. Bowel care is not usually required, but if constipation persists, it should be considered. Since nerve monitoring is often used, careful attention must be paid when using muscle relaxant. LIF carries a risk of bilateral injury. Therefore, intraoperative observation for macroscopic hematuria is important. But if the ureteral catheter itself causes trauma during insertion and leads to hematuria, it becomes difficult to assess. Rib resection may be necessary if the surgery is performed at a higher level. Rib resection may be required. This is video of the actual surgery recorded for the lecture. A microscope is not required. The skin is incised and the fat is separated. The lateral abdominal muscles are often divided to enter the retroperitoneum. And now you can see the fat, and this is muscle. And we can find psoas muscle through retroperitoneal fat. And using monitoring devices, we pass through the pulsars and access the vertebral body. A dilator is placed and a specialized retractor is set up. The intervertebral disc is often cleared to create space for the cage to be portioned as shown. Although not common, several complications can occur, including vascular injuries, bowel injuries, and ureteral injuries. LIF is one type of MAS, but the issue is that if complications occur, they can be fatal.
I will present a case where the segmental artery running alongside the vertebral body was injured. There might have been an issue with wire technique, but occasionally the segmental artery can be damaged. In such cases, without panicking, we control the bleeding by applying pressure on bleeding point. During this procedure, 10 cm long bipolar forceps is necessary. This is the segmental artery.
Postoperative care is similar to that of 𝒂𝒓. Patients may experience temporary difficulty in lifting their legs on the approach side, or temporary sensory disturbance in the thigh. I have explained several types of MIS. The procedures I introduced are just a portion of the MIS performed in Japan. MIS requires specialized equipment and surgical tools, so the indications and the method may vary depending on individual hospitals or regions, while the fundamental principles are the same as traditional open surgery. Learning the specific points of each MIS techniques will allow you to handle various types of MIS. As new MIS techniques are likely to emerge in the future, please take sure to share information with physicians when new techniques are introduced. Thank you for your attention.
Okay, thank you very much, Dr. Yamamoto. Thank you very much for your beautiful presentation with a lot of motion pictures, which are very impressive. And his topic ranged from endoscopic spinal surgery to minimal invasive spine fusion. So he mentioned not only tips of surgical techniques, but also postoperative complications and the surgical preparations and postoperative patient management. So he also gave detailed explanations about intraoperative procedure and note of caution from nurse's perspective. That was very wonderful and very good for this webinar. So we have two commentators. We are inviting two commentators to give comments and suggestions. So Professor James Wang and Dr. Liu Sang, please give comments or suggestions and opinions about his presentation.
Hi,
So,
this is Dr. Wang from Beijing here. Can you hear me?
Yeah, you can hear
Okay.
that. Yeah.
Well, thank you, Dr. Yamamoto, for the excellent presentation. I think certainly MIS becomes more and more popular every day. As a matter of fact, some of our spine patients came to our clinic. When they decided to go for surgery, they will tell us, I only want minimum invasive surgery. Although they don't, as a layman, they don't understand what MIS really entails. So I agree with most of you said MIS usually associated with less bleeding, less pain, shorter post-op hospital stay, and all that. But some patient misunderstand as MIS is without risk, which is obviously not true. So we have to make it very clear to the patient. And you also mentioned several surgical indications for MIS, discectomy, blah, blah, blah. I agree with all that. But we have to keep in mind there's something that we should not consider doing MIS, like intradural tumor, intramedullary tumor, for example, or redo surgery or multi-level fusion and fixation. Those are probably too much for the MIS. Finally, I have a slightly two different opinion about Dr. Yamamoto, your two statements. One, you mentioned the MIS usually associated with less screw male position. Well, that's not my experience. I think whether you can put the screws accurately have nothing to do with it, whether screw is through the tube or through the percutaneous approach. If anything, it's making it more difficult because you have no bony landmark. You completely rely on your x-rays or navigations. That makes the screw positioning more difficult. The second is you mentioned in one of your slides, in order to find out the hematoma, you let the patient stay in the hospital for a week routinely. Well, I guess that's depending upon what kind of surgery you're doing. If you're doing a one-level discectomy, foraminotomy, or simple partial discectomy or laminectomy, well, the United States insurance company will not allow you to keep the patient for a week. They only give you 2 to 3 days. If you let the patient stay longer than 3 days, you better write a statement to the insurance company to say why. Maybe in Japan, it's more lenient to the patient. But certainly for a simple MIS surgery, most of them you can discharge them with early ambulation and rehabilitation in 2 or 3 days. I think that's possible. Well, thank you. Back to you, Dr. Nishimura.
Okay, thank you very much. So, Dr. Yamamoto, can you say about screw mount position? Do you think that putting a screw is more precisely placed? The screws that can be more precisely placed in the MIS procedure than the open procedure?
Yeah, thank you for your comment.
Yeah.
I agree with you. So I said I routinely use the intraoperative CD and the navigation system. So I can insert the screw exactly the place. So I usually don't use only fluoroscopy. So and you mentioned the hospitalization for a week. It depends on the countries and the hospitals, I think. So Japan has very good insurance for patients. Thank you.
Oh, thank you. So you always use OM navigation. So
Yes.
you say that it's OM navigation is more precise, much more precise than the fluoroscopic guidance, right? Okay,
Yes.
so
Yes.
and the frequency of possible hematoma is less than open surgery.
Not less. I have no case, but the surgeons, a lot of surgeons said the hematoma is more
Okay.
frequent in MIS.
Okay, so it's almost the same as open surgery.
Almost same,
Okay.
but yeah.
Okay, thank you. So we have another commentator, Dr. Liu-san. Can you give any comment?
Yeah, thank you. Thank you, Professor Yamamoto, for a very nice presentation. Basically, I have three simple questions. We have biporter and uniporter system for MIS for spine. In my personal opinion, uniporter are the real minimal invasive because I feel that biporter is almost like how we do a transsphenoidal surgery. Where the opening is quite a lot. I think the bony removal is quite more. I just want to know about your opinion regarding the difference between uniporter and biporter system. My second question, Professor, is regarding the accuracy. And you mentioned that in endoscopic surgery, wrong level is quite risky. So may I know in your workflow, would you actually put a marker and repeat your OR system, to identify the level before you really do the bony opening for MIS endoscopic surgery? And my third question is on the true definition of MIS, because endoscopic MIS, because some procedure, for example, like putting a spacer, intervertebral disc placement, or pedicle screw, actually we still go back to the old method using the II guided rather than true endoscopic guided. So in this procedure, when we taking a consent from the patient, would you actually mention that not all the procedure actually are endoscopic based? Some procedure, for example, is pedicle screw or spacer, that you may need to use II base. May I know your opinion? Thank you.
Okay,
Thank you. Thank you for your opinion. So first question you said
biporter and uniporter.
Biporter, yeah. So I have not much case of single porter endoscopic surgery.
I prefer bipolar. So I have so because it's simple for me because we can use the same instrument of open surgery, so it's easier for me. So, but in Japan, a lot of surgeons with endoscopic surgeon uses single port. It's more familiar in Japan.
Do you think that the bony removal would be different, more in biporter, less in uniporter, or think no different?
I think uniporter is more less invasive. Uniporter is better for MIS, I think.
Thank you.
Because we do when we do biporter, we have to make I don't
wider opening.
Yeah, wider. Yes, the tissue damage more.
Yes,
we do. Yeah.
Okay, so Dr. Yamamoto, can you mention about the precise localization of endoscopy intraoperatively?
Yeah, I have no case, but my surgeon said that, so I want nurses to know that. So I said.
So you check repeatedly with the horoscopy for
Yes,
level,
yes, that's right.
localized
Yes.
level. Okay,
Yes.
okay, thank you.
Yes, of course.
Okay, so we had a very good discussion from minimally invasive spinal fusion and this endoscopic surgery, and Dr. Yamamoto gave a good, beautiful presentation. Okay, thank you very much for your making time in your schedule. Yeah, I want to close this session. Thank you.
Thank you.
Thank you, Prof. Yu Yamamoto. Now I should call upon Christine to chair the second session. Christine?
Yes, I'm here, ma'am. Yeah, my sound is clear. Yeah, thank you for Professor Isuke Nishimura for the lead, the one session, and now we will into the second session. And for the second session, we have session chair Professor Nadia Krishnan. Professor Nadia Krishnan, are you there?
Yes, yes.
Yeah, okay.
Good afternoon to all.
This your please time and screen. Thank you.
Good afternoon to all. I hope I am audible.
Yes.
Yeah, you are. Yes.
Yeah, thank you. Thank you. I would like to thank at the outset for this opportunity to be part of this session. I am Nadia Krishnan. I am working as a faculty in AIIMS Bhubaneswar, that is All India Institute of Medical Sciences, Bhubaneswar. My specialization is in critical care. I'm also a member of the Society of Indian Neuro Nurses. Thank you so much. I would like to start with inviting the next speaker, that is Ms. Danya Shashi. So she is a nursing officer working in Neuro Operation Theatre of Sri Chitra Tirunal Institute of Medical Sciences in Kerala. And she is a master's in nursing, and she has done various courses in CSSD and conducted by universities of Kerala. She has membership in different societies, neuro and psychiatric nursing, and she has collaborated in some clinical projects, and she has done multiple presentations. So I invite Ms. 𝒂𝒂𝒂𝒂 to speak on the topic of nursing care of patients post-spinal surgery. Over to you, Ms. Dhanya.
Please unmute yourselves.
Unmute yourself. Okay.
Okay.
Am I audible to all?
Yes.
Thank you, and very good afternoon to all, and welcome all to my presentation on nursing care of patients post-spinal surgery. I'm going to share my screen. I hope my screen is visible to everyone.
Yes.
Yes.
So I can continue, ma'am.
Can you put into presentation mode, please?
Yes, ma'am.
Can you please change it to the presentation mode?
Yeah, sure, ma'am.
Okay.
Great.
Please unmute your mic again.
Please unmute.
It's already unmute, ma'am. Am I audible to all, ma'am?
Yes.
Yes. Thank you. I thank the organizers for inviting me to this presentation, to this webinar. Welcome to my presentation. It is nursing care of patients post spine surgery. To start with, spinal surgeries are complex procedures that addresses various conditions like herniated disc, spinal stenosis, tumors and other structural lesions, degenerative disorders, and even we do spinal instrumentation and fusion surgeries, which involves joining two vertebrae to prevent the movement and stabilize the spine, and there may be interbody fusion also. And there are surgeries addressing the structural issues of the spine, like kyphosis, kyphoplasty, and spinal instrumentation is also there with rod and screw systems and plating system for anterior stabilization. Just like the slogan goes, catch them in, that post-operative nursing care, it have to be if it has to be completely undertaken, it should start from the preoperative phase itself, which include the first and foremost patient assessment, which involves a comprehensive history, including the detailed medical, surgical, and comorbidities, and the preoperative drug use, medicine use, neurological assessment, and physical examination, with special attention to spinal alignment, range of motion, or any deformities. It also involves patient education, which involves a procedure overview in which all the basic steps involved in the procedure, the expected outcomes, the potential risk, and the basic preoperative routines will be explained to the patient, and along with the anesthesia information regarding the type of anesthesia and what to expect during the procedure. The pain management plan will also be intimated to the patient before surgery. And also it involves basic post-op routines, vital signs monitoring, frequent wound rest checks, and debriefing sessions. All these things will be explained to the patient in the preoperative period itself. And we should explain to the patient regarding the position strategies like log rolling technique, and what is the rationale for maintaining proper body alignment, and what are the risk of twisting, pulling, and stretching and straining after surgery, and what are the correct technique of getting out of the bed. To continue with the preparation, certain diagnostic procedures like MRI, CT have to be undertaken before the surgery, and informed consent have to be taken, which have legal and ethical implications, And there are certain preoperative instructions too, which involves the guidance of fasting, medication adjustment, and health monitoring. Last but not the least, psychosocial support is also very crucial so that it helps in anxiety management and reassurance. Support system can also be involved in the postoperative care of the patient. We all know about the surgical safety checklist introduced by WHO to reduce the complications associated with surgery. So in spine surgeries also we use a checklist, but in addition to the routine things, we have to add certain elements in the spine checklist for spinal surgeries, like routine OT adjuncts. What are the adjuncts we are going to use in the spinal surgery, like microscope, CM and navigation, neuromonitoring, and implants. Regarding implants, which is the company which is supplying the implants, and the screws, rods, what are the kind of plates available, and if we are using any graft, it can be a local graft or an artificial graft. And next, regarding the collar and corset the patient have to use in the postoperative period. Corset will be used for patients undergoing thoracolumbar surgeries, and collars are for patients undergoing cervical laminectomy. The correct size of the patient's collar should be assessed before the surgery and have to be obtained so that the patient can use it comfortably after surgery for stabilization. And regarding the intra-op elements, it include positioning and confirmatory images, the gauge counts, and final tightening of the top screws, and even the use of local antibiotic powder after the fusion. And in the post-op checklist, we have to include the vital checks, neuro checks, post-op plan for physiotherapy, and sample dispatch, red flag signs, and what are the red flag signs we have to be worried about, and the physician reviews and discharge advice. It is research-based evidence says that the safety checklist decrease in mortality rates, and so that is the importance of safety checklist. And then as soon as the patient comes to the ICU, we receive the information that the surgery is over and the patient is coming to the ICU. Better to avoid the number of shifting, like from OT table to the ICU trolley, and then from ICU trolley to the ICU bed. Instead, we can shift the patient directly to the ICU bed to reduce the number of shifting. And we always say log rolling is a golden rule in transferring and position change of the patient undergoing post-operative in spinal surgery. And we always need people to execute it. So always try log rolling with a lot of people around you to help you to assist with the safe transfer of patient. Always a flat bed is preferred, and the patient will be having a lot of tubings like ventilator tubing, spoon drains, and epidural catheter and central lines. So in case of anterior cervical surgeries, always anticipate tracheostomy, and the tracheostomy tray have to be prepared. Most of the patients will be having nil per oral on the day of surgery, especially anterior cervical surgery. So that gag reflexes have to be checked before the oral feeds, and so that clear fluids can be started on the first post-op day. And early ambulation is a golden rule in all spinal surgeries. Then regarding the postoperative nursing problems, its first and foremost problem is the pain, and the area of the pain depends upon the area of the surgery. For lumbar surgery, patients will be having lower back, abdomen, thighs, and cervical patients. Patients undergoing cervical surgery will be having upper back and shoulder, neck, and arms pain. Anterior cervical patients will be having difficulty in swallowing, along with a difficulty in breathing or sore throat. Causes may be tissue trauma, muscle spasm, or nerve root compressions. And there are certain risk factors identified by a group of researchers, which includes elevated anxiety, depression, pain catastrophizing, pain sensitivity, and preoperative opioids use, and female gender. Preoperative opioids use always have a negative impact in the postoperative care, not only in pain, but also in certain other nursing problems, which I'll be discussing later in this presentation. The usual interventions for reducing the pain is first and foremost regarding the bed position to reduce the stress to the operation site. And for cervical and anterior cervical laminectomy, head of the bed is usually elevated, but now setting is always the head is means the bed is flat. Anterior cervical, you can provide a small pillow to prevent flexion, extension, and rotation of the neck, and even a soft collar while the patient is lying down. And hard collar will be used for patient after the patient has started ambulating. Lumbar laminectomy also, flat position is preferred with pillows to support the knees and head. Log rolling technique is again and again we are stressing the importance for proper body alignment and keeping the spine in neutral position so that we can avoid twisting, flexing, and hyperextending. And the pain relieving strategies can be non-pharmacological, including imagery and relaxation techniques. And we can even assess the response of the patient using a visual analog scale. And pharmacological interventions include analgesics, epidural analgesia, which include lignocaine and buprenorphine combinations. And while starting epidural analgesia, always watch out for paresthesia. It's a crucial nurse's responsibility. Transdermal patches can also be of great help in reducing the postoperative pain. These are some of the medications and can be non-steroidal anti-inflammatory drugs or ketamine infusions or even opioid preparations for reducing the pain of the postoperative period. Next important problem is ineffective airways. We encounter this problem usually in the anterior cervical cases, in which there is swelling of the perivertebral soft tissue and in the immediate postoperative period. And the reason can be a compressive hematoma, which can result in airway obstruction. CSF leak, usually we take great care not to avoid dural tear, but once it happens, CSF leak can result in a swelling, and that can also contribute to airway obstruction. Very rarely, bone graft can extrude out and cause an airway obstruction. So whatever be the cause of airway obstruction, an airway assessment has to be done. And as I already told, the tracheostomy tray have to be prepared. And you have always anticipated an emergency re-exploration of an operative hematoma if that is the reason for airway obstruction, and secure the wound drains. If the wound drains are obstructed, again the blood can be collected and result in operative hematomas and consequent airway tract obstruction. And so in this case, even if wherever this perivertebral edema is not subsided, if it is unresolved, we have to anticipate emergency reintubation in the postoperative period. General care also follows, which include debriefing sessions to hourly and early ambulation. And coming to urinary retention, which is another important problem, urinary retention can be due to many reasons. Both central and peripheral mechanisms are involved in the suppression of maturation reflex because of the effect of anesthesia. And the infusion of the intraoperative fluids are also can be a reason why this patient having urinary retention. And difficulty in voiding in horizontal position. Most of the time, the patients are relying in the bed in the first postoperative day, so that difficulty can be there. And there are certain risks. Then opioid use. I told you that opioid use can be a negative role in postoperative management, because opioid use and both surgical pain can increase the sympathetic nerve stimulation and result in bladder muscle relaxation, which increase in volume of the bladder, but at the same time, the bladder neck contracts. As a result, the patient will be experiencing postoperative urinary retention. So these are some of the risk factors identified again a group of researchers, which include older age, male sex, renal failure, diabetes, depression, pre-opioid use, benign prostatic hyperplasia, increased operative time, and total intravenous fluids and spinal anesthesia. Pre-opioid use again comes to play a negative role here also. And these are some of the interventions. We can assess the risk factors and assess the bladder function. Provide enough privacy and comfort so the patient is not feeling any kind of embarrassment during this maturation. Early ambulation is another crucial factor. Pain management strategies, if it is effective, it can also reduce urinary retention, because patients' coping strategies with bladder training and intermittent clamping of catheter will improve if we maintain the pain properly. Suprapubic hot application is another therapeutic entity we can use for reducing the urinary retention, and also pharmacological measures like tamsulosin. Intermittent clamping to assess the bladder fullness sensation and removal of indwelling catheter is always advised as early as possible. And progressive strategies, if any kind of urinary retention develop, you have to adapt progressive strategies like a trial without a catheterization, followed by intermittent catheterization, bladder training programs, and indwelling should be considered only if necessary. And if all these problems persist, you have to consider a urological evaluation. Next is regarding nutrition. Nutrition is not of a great concern in patients undergoing laminectomy, apart from their comorbidities they experience. But in the case of anterior cervical dscectomy or laminectomy, it's of a great concern, because the same mechanisms which result in airway obstruction can act here and result in an esophageal retraction, and also again swallowing difficulties follows. So in case of any swallowing difficulties, we can resort to comfort measures, and a diet rich in protein and fibers can be followed in the postoperative period. Then constipation. The causes of constipation may be use of anesthesia and specific type of pain medications, then decreased activity levels, increased stress, and decreased mobility. Often we used to oversee constipation as a minor complication, but constipation can have a bearing in the postoperative period because training for defecation can cause wound dehiscence and other related complications. Apart from that, it can have local complications like hemorrhoids, anal fissure, and rectal prolapse. So the usual interventions of constipation follows here too, like auscultating the bowel sounds, assessing the abdomen, early ambulation, and physical therapy, so that's stretching. All these things aid with the bowel movements. Increase in fluid intake and diet high in bulk and stool softeners can also be used to address this problem. Sensory perceptual alterations is another important problem which the patients face in the postoperative period, and the main cause is a nerval compression. We have to monitor the perception to light, touch, and pain, and also sensations like crude touch, because light touch, pain, and crude touch are having different nervous tract, so that assessment should be proper. And proprioception can also be affected in some cases because these are handled by different nerve fibers, different set of nerve fibers in the spinal cord. So in order to compensate for this loss of proprioception, we have to compensate for, teach the patient to visually check the position of the extremity, and then followed by gentle touch, regular position changes, pressure relief measures, temperature regulation, and balance training aids a lot in addressing the sensory perceptual alterations in patients undergoing spinal surgery. If the sensation is affected, motor part is not also extended, motor parts are also affected. So impaired mobility is another problem. So pain, tingling, and muscle weakness can be the cause of impaired mobility. So we should monitor the ability to move the extremities compared with the pre-op baseline data, and range of motion exercise comes here too. And the patient can use assistive devices like brakes and walkers. And we have to consider progressive mobilization. As I already said, in the anterior cervical discectomy patients or laminectomy patients, soft collar is used in the lying down position and hard collar is used for ambulation. And this is how we should, in the lumbar laminectomy ambulation, actually we need more people to assist the patient from the bed to an erect position. At least we need 2 nurses to assist the patient to the erect position. The bed is either flat or slightly elevated. The patient is positioned close to the edge of the bed and he's positioned on his or her side, knees and hips slightly flexed. And 1 nurse will stabilize the upper trunk and 1 will support the hip region. And after the count of 3, the patient will be assisted to the upright position. As a first venture, a few steps to the door and back can be done, and after that, gradual greater distances can be covered. In the case of cervical laminectomy, the head of the patient can be slightly elevated and align the patient to the edge of the bed, stabilize the upper back, support the below knees, and assist the patient to a standing position. And to address the problem of infection, which is a common problem with all surgeries, we have to observe the dressing, drain site for blood and CSF, the presence of blood and CSF. The incision have to be monitored for swelling, redness, drainage, irritation, and pain. Strict aseptic precautions have to be followed to prevent infection. Prophylactic antibiotics, of course, is an integral part of managing infections. And wet dressings have to be changed if necessary. In case of spinal instrumentation, we may have 2 incision sites, like a donor site. If the graft is taken from an iliac crest or the rib region, that site also have to be given sufficient consideration, so that undue pressure on the donor site should be avoided. That area dressing have to be maintained, monitored properly for sterility and other instability and any abnormalities in the drainage in the dressing of the donor site. And the concern is the collars and braces and other supportive devices worn by the patient. If it is not of a proper fit, it can cause skin irritation and other complications like abrasions, irritation, and friction injuries. That is why I always insist that a correct size of supportive devices have to be obtained in the preoperative period to avoid all these things in the postoperative period. And coming to DVT prophylaxis, there are a lot of risk factors associated with the development of DVT, like prolonged immobility, prior venous thromboembolic event, extremity paralysis, and preoperative steroid use. And of course, the multi-stage surgeries will prolong the duration of surgeries and again put the patient under the risk of developing DVT. To manage DVT, of course, we should monitor the vital signs and the neurovascular assessment of the extremities is crucial. Sequential compression devices are preferred more than anticoagulants, because anticoagulants have to be used with caution. And most of the patients with comorbidities like heart problems or any coagulation problems, in anticoagulants can result in the development of epidural hematoma. So sequential compression devices really have an upper hand in managing patients with DVT. Early ambulation and range of exercises here to also have a beneficial effect in preventing DVT. Next are the rehabilitative considerations. In the rehabilitative consideration, we should teach the patient proper body mechanics and lifestyle modification, and regarding the use of assistive devices and pharmacological management, especially pain management. And while the patient use opioids, it's always there is a tapering regime, and there is a incidence for misusing the drugs. So all these things have to be taken care of. And in the discharge teaching program, again, body mechanics have to be properly stressed, adequate supporting mattress and chairs, and optimum weight maintenance, and regular sessions of exercise with the physical therapist like sit-ups, pelvic tilt, knee chest, and any modification in activity of life, daily living like climbing stairs and lifting have to be specifically mentioned. What are the precautions the patient have to take while doing all these activities? Next, of course, psychological support do a great deal in the postoperative recovery of the patient, so that realistic goals can be set, and patient can develop strategies to reduce stress and anxiety. And there are a lot of relaxation techniques like guided imagery to address the problems of psychological support. So spinal surgery is also not free from complications, even though, and the most common complications include hematoma, CSF fistulas, arachnoiditis, nerve root injury, and postural deformity. Hematoma, if the patient is having severe pain and which is not relieved by analgesics, and again we see the deterioration of motor and sensory functions in the extremities, we should always suspect a hematoma formation and always anticipate an emergency re-exploration. That is the only way to evacuate a hematoma. So all these symptoms, if it develops, you have to notify the surgeon immediately and anticipate immediate reoperation and evacuation. Because if the hematoma is left untreated, it can result in irreversible motor and sensory deficits and bowel and bladder dysfunction. Then CSF fistula, most of the laminectomies in which dura is not open, this CSF fistula is unlikely to develop. But in certain cases, if there is an accidental dural tear, it results in an abnormal connection between the subarachnoid space and the incision site, and it can also lead to an impending meningitis. Sometimes this CSF fistula is usually evidenced after 1 week. So when we check the dressing, if it is wet always, increased drainage, and if the drainage is tested positive for sodium, then CSF leak can be suspected. So in case in case it develops, prophylactic antibiotics to combat infection can be there. But if the dural tear or the CSF leak is not sealing off it spontaneously, then a surgical repair is always anticipated. Then arachnoiditis is another complication of spinal surgeries in which the inflammation of the arachnoid layer, it can be caused by scar tissue or contamination. It leads to adhesions and severe pain to the patient. And if pain again not reducing in the postoperative period, we can suspect arachnoiditis. We can we can start interventions to combat infection like antibiotic therapy. But if the pain is persisting and it is severe, then surgical intervention to remove adhesion should be considered. Nerve root injury is another problem of concern, complication of concern in spinal surgeries. A sustained pressure on a nerve root from a hematoma or a CSF leak can result in nerve root injury, can lead to foot drop, hand and arm and weakness. If it is suspected, aggressive physical therapy and steroid therapy like dexamethasone or methylprednisolone can be considered to reduce the edema and improve the function. Again, range of motion exercises is of great help here also to prevent contractures and musculoskeletal deformities. Finally, the postural deformities is another final complication of the spinal surgeries. It usually happens in laminectomies, which involves more than one level in the vertebral column. Early ambulation and good body mechanics will do a lot to prevent postural deformities in the post-spinal surgery patients. But in extreme instances, we have to consider a spinal fusion. To conclude with, nursing management of postoperative spine patients is a multidisciplinary team approach effort, and there are a lot of multi-phased interventions involved in the care of these patients. And not only there are a lot of interventions, but all these interventions have to be properly coordinated for the optimum outcome of the patient. And also there should be a strict watch out for the complications so that we can easily identify early the complications and prevent the complications to a great extent. So finally, as a take-home message, all the healthcare workers involved in caring the patient after spinal surgery, together we should help the patients to stand straight. Thank you all for your patient listening. Thank you, all the organizer, for inviting me to the presentation. Thank you, ma'am. Thank you, sir.
Thank you, Ms. Danya, for that very comprehensive presentation on nursing care of patients with spinal surgery. You have covered all the aspects, right from the pre-operative care to the post-operative issues and ways to mitigate and manage these problems. So it was a very comprehensive and informative presentation. Thank you so much.
Thank you, ma'am. Thank you, ma'am. Thanks a lot.
So with that, I would like to invite, we'll go ahead with the second presentation from the nursing aspect. I would like to invite Ms. Liu Miao for the next presentation. And she has had her education in Xingtai Medical College and again in China Medical University. And she has had her internship experience in Beijing Friendship Hospital. And she is currently working in the neurosurgery department. And she has participated in multiple programs in the neurosurgery department. And she has been involved in the treatment of patients with spinal cord, brain trauma, and intracranial tumors and other neurosurgery patients. And she has been awarded like multiple times for excellence awards, and she has been again awarded as an advanced worker in college level. So with this, I would like to invite Ms. Liu Miao for her presentation on nursing care of patients post minimally invasive spinal surgery. Over to you, ma'am.
Thank you. Hello everyone, I'm Miao Liu, the head neurosurgical nurse of Beijing Tsinghua Chang'an Hospital, Tsinghua University. It's a great honor to have the opportunity to share the nursing experience after neurosurgery. This case that I'm talking about is mainly about spinal tumor perioperative nursing case. As we all know, challenge of the complex intramedullary tumor not only for neurosurgeon but also for neuronursing during preoperative period. I will share this case according to the following 5 aspects. First, case including introduction. Our patient is a 40-year-old female. She's main complaint is that back pain. Left hand numbness for 11 years. Limb weakness for 8 years. Aggravated for 7 months. The following left MRI is the first hospitalization of care in our hospital, and the right MRI is the result of this hospitalization. We can say from the MRI, 7 months of time, the patient's tumor mass has made significant progress. In terms of her background, she had no previous medical illness, and her vital signs within normal range. She is and honored. pupils are normal except for she has bilateral safer lip and below sensation decreased bilateral lower limbs, muscle stress discrete and tendon reflex abnormalities. The following are the first events of the patient during hospitalization, admission, program, and discharge. The following picture are the total resection of the tumor in our operation. The tumor is 35 centimeters in length. To our knowledge, this is the longest ependymoma in the literature. Then from the following three aspects, the patient psychosocial safety and education. According to the psychosocial assessment scores of patients after admission, the corresponding psychosocial counseling and support were given. Regarding of the safety, the first we need to keep her skin integrity and monitor her erections winters. Make sure patients' urinary and bowel function were normal. Also, prepare the surgical theater. In terms of preoperative health, education, pain management, and private complication are essential. Demonstrate the use of patients come to anesthesia pump if prescribed. Instruct the patient is deep breath and coughing techniques. She can understand the importance of performing the techniques positively to prevent to development of pneumonia at lecture size. According to the VTE score, patients were given measures to prevent thrombosis, like compression socks and sequential compression device. The third part is the postoperative nursing management. Divided postoperative nursing management into the following three aspects. Team observation. I will start from vital signs to assessment and pain management. The stability of the patient vital signs is the first step in good postoperative recovery. According to head-to-toe assessment, central nervous system records the patient's mental state and GCI score, cardiovascular system, respiratory system, we have many patients have the problem of breathing due to cervical spinal surgery. Airway management is particularly important for patients. Gastrointestinal tract nutritional support was given to patients according to the nutritional risk score. Renal system. Some patients have urinary relation due to spinal cord surgery. We also provide blood function training, musculoskeletal constant. If patients have problem with mobility and rest in bed after the VT scholar inquiries recess, we will give the tailored guidance to provide strong process. Hygiene and skin. Overall skin assessment. If they have the risk of pressure injury, what we should do is that prevent pressure injury as much as we can. On presence of wood dressings, dry and intact or not. If there has any drainage, the drainage in situ, patents and drainage, fluid parties and amount. In terms of specialist observation, I will follow the following of three aspects this part. Assess patient's mental state and GCS score compared with preoperative. Assess patient pupils. Assess muscle toner, including through and equality, some synthetic sensation, especially for whose people have spinal surgery. Access turnover. Access turnover is a technique which can help patients keep them spine stable and contribute spring healing progress. Cerebrospinal fluid leaking. There are some patients have the issue with cerebrospinal fluid leaking due to spinal mental healing unaware. This is a big challenge to us. So we do encourage our patients keep position if there are no restriction. Prevent complications. Prevent hemorrhage, pneumonia, urinary tract infection, venous thrombosis, and wound infection. The fifth part is rehabilitation. The perfection team collaboration is crucial for the comprehensive management of patients with intramedullary spinal cord tumor. This team typically comprises 𝒂𝒂𝒆𝒔 professionals including neurosurgeon, neurologic, critical care nurse, physical and occupational 𝒂𝒂𝒆 and 𝒂𝒂𝒏𝒂𝒂 physician. Each member brings unique expertise and perspective to a table, contributing to the effective needs of patient care. The last page is follow-up. In terms of follow-up, will stem from patients recover, instructions that they need. Referred time is assessed by doctor and advice which they have for our nursing during the hospitalization. The above is what I share. Thank you for listening.
Thank you, Ms. Liu Miao, for that presentation of a case who has undergone spinal surgery for removal of the ependymoma. So we have whatever you have discussed. It was similar to what Ms. Danya had discussed at the nursing care. The thing we could relate with some patient case. So the first one can be said as a theoretical discussion, and you have tried to put it in a case. So it was a nice presentation, and thank you so much. With that, I would like to hand over to Professor Yusuke Nishimura for invitation for the commentators. Thank you so much.
Thank you.
Prof. James and Dr. Liu, can you please comment or give any suggestion to the two presentation?
Okay, so I'm very impressed that how actively now 𝒂𝒂𝒂𝒂 on the critical roles in the spinal surgery management in India and China. I hope that the increased number of nurses are more interested in the spinal surgery. So I want to invite commentators give some comments and suggestions. So Professor Wang, can you give any comment?
Well, thank you. First of all, I think Danya's presentation covers the most important point from nursing point of view, how to manage the post-operative spine surgery patient. I'm not going to reiterate any points here. I just want to comment on one thing, which is the post-operative pain control. I mean, in the last 10, 20 years, we've been more using the PCAs more and more liberally. I think partially it's because it's more effective, partially because maybe the surgeon was easy. So write a post-op order, PCA is simple, rather than writing several meds, PRNs. But there's many occasions when I make round post-op, I will see the patient just curled up in the bed, still in a lot of pain. I mean, the pain control is crucial for early ambulation and early recovery, early discharge. So I think the frequent pain assessment from the nurse at the bedside after surgery is crucially important. I think many of us, including the nurse, just gave a minimum dose of PCAs, which is not enough. So they are afraid if you give it too much, you have to deal with the overdose, a bunch of other complications. There's one thing I want Danya to make a comment. I noticed that in India, you also use ketamine for pain control, which is something I never do. I routinely use the narcotics like morphines or fentanyl or non-steroidal anti-inflammatory agents, but I never use ketamine. I know that I use ketamine in animal experiments, and some anesthesiologists use ketamine for the anesthesia. Maybe you can tell us some of the advantages of using the ketamine for pain control over narcotics and NSAIDs, so that we can all learn something. The second Liu Miao's case is just absolutely a dramatic case with an ependymoma of more than 14 or 15 segments. I think as a surgeon in our career, we're probably going to see less than 5, maybe 3 cases of ependymoma that long. And even in the best hand, and those patients are a big challenge for the surgeons. And usually after the surgery, regardless how careful you are, the patient is going to have a deteriorated neurological function. There's a lot of weakness and loss of bowel and bladder function. But fortunately, most of the functions come back in about 3 to 4 months with active rehabilitation. So obviously, those patients are a big challenge for nursing as well. Liu Miao mentioned a big challenge is the CSF leak because it's such a long dural incision, and it's very difficult to make a complete watertight dural closure. So maybe Liu Miao can tell us if you find a lot of drainage from the drain or from the wound, what looks like a serous sanguinary fluid, other than putting the patient in a prone position, and maybe let the resident oversew the skin a little bit if the leaking is not too much. What else can you do? And from surgeon's point of view, whether you go back in to repair the dura or put in the lumbar drain, and when you should consider that. And also tell us, how can you tell those drainage fluid is from CSF? What kind of test that you should go? Thank you. Back to you.
Okay, thank you. So, Ms. Danya, so can you comment on the using the ketamine for spinal surgery, pain management?
Please unmute your
I think
mic.
you are muted.
Am I audible, sir?
Yes, we can hear.
Yeah.
Yes.
Thank you, sir. Thank you, sir. Thank you so much for your comments and suggestions. Sir, in our setting, we also don't use ketamine as a pain control measure. We depend on buprenorphine and 𝒂𝒂𝒏 preparations for achieving pain control. Ketamine is not used, but it was used in the initial years, and that was the dose of ketamine which we. It's actually from a general point of view. I talked about ketamine, but ketamine is not used nowadays as you said, sir. It is not used nowadays as buprenorphine or 𝒂𝒂𝒏. There are because it has all the pain relief measures. Opioid have similar advantages with ketamine, and also less risk factors are also there. So we are also using opioids instead of ketamine. Ketamine is not used now sitting also, sir. Thank you, sir. Thank you so much for your suggestions. And it was just that if it is used, in our case, it is used. This is a rose. It is that was my intention, sir. So because ketamine is not used nowadays in our institution also. It is we usually depend on this epidural analgesia and transdermal patches. That these are the pain control measures which we follow, sir. Thank you, sir.
Yes, thank you. So, Ms. Liu Miao, can you give a comment about CSF leakage and the draining management of spinal surgery patients?
I think the dressing as the word of the patient was right, repeatedly, and the cold liquid was obviously listened to exceeded from the instance during dressing check, and patients often present as 𝒂𝒂𝒒𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂 headcurse. I think so.
Okay, so thank you very much. So
Nishimura Sensei, so maybe maybe you may ask Dr. Wan how he can treat about the CSF leakage, how long he can wait or back to the operation theater, or can you ask him, please?
Oh, hi, Dr. Cato.
Hi,
Good to see you.
Hi, hello, how are you?
Hi.
Thank you for your comments.
Yeah.
So,
well,
yes.
If the CSF leak is mild,
yeah.
I usually let my resident to oversew the skin, to give them a couple of days with the best hope. I'll put them in a prone position. But if the patient kept having low pressure headaches and the CSF leak is coming either through the skin or through the drains, and I'll test it with a glucose level and transferring those things. If I'm sure it's CSF, then in my hand, I usually failed with conservative management. So I probably take back to the OR after 5 days with a lot of CSF leak. to put a lumbar drain in those patients is difficult because you just did a major surgery, you have no laminars there. So if during the surgery, at the end of the surgery, I feel like I can't make a border tight dural closure, I put a lot of fibrin glues, and then I put in the lumbar drain then. Yeah. Because once you close the skin, you put a lumbar drain in the X-ray department is extremely difficult and dangerous. That's my personal bias.
I understand. Thank you so much.
Okay. Thank you. Thank you, comment. So, Dr. Liu Sam, can you give any comment?
Thank you.
Presentation?
Thank you for both excellent presentation. Just to add on the pain management now under ERAS, we do have pain management even before surgery. I think this is very important, either by education, by diet, and by pre-medication before surgery. I think this should be emphasized. And there are some practical issues. I'm not sure whether people are doing, for example, like clamping the CBD because some urologists do not agree with it, or obviously doing it. And another important, I think, is the temperature, room temperature. I think patient sweating after surgery is not good for wound healing. I think that is important. And also important for the nurses is to know the red flag. Red flag means if there's sudden paralysis, then we should inform our surgeon. I think important for nurses to know all the red flag in spine surgery. And one important, probably I want the opinion from the nurse, because for doctor, usually we see our patient after surgery. We know what happened in OR, but for nursing, they don't do the same. So I wonder if the nurses in OR would now go to ward and see their patient. For example, patient who have a pressure sore in OR, where the OT nurse observes some pressure sore, they may be the best person to go to the ward and see the resolution of a pressure sore rather than another nurses in the ward. Probably the nurses can give me their opinion. Thank you.
Okay, thank you. So, okay, so can you give any comment? Ms. Sashi, Daniel Sashi?
Sure, sir. Thank you, sir, for your comment, and thank you for reminding about the temperature changes which can result in sweating, and again, which can have a bearing on the wound healing. Regarding the pressure sore, yes, sir. OT nurses can observe pressure sores and also see to the recovery of the stages of wound healing in the pressure sores. They can even visit the patients in the ward. Most of the time, we myself have, or in our operation room, nurses also have the experience of observing pressure sores which were not identified by during the preoperative examination, and we have even intimated the surgeon regarding the presence of pressure sores. And all these things, OT nurses also have an important role in observing the changes in the skin, which can result in post-operative increasing the infection incidence. Thank you, sir, for your comment, and that was a very crucial point, sir, because in my personal experience, we also had minor abrasions and certain burns. Sometimes it can be missed in the preoperative period, but as soon as the patient comes to the OT, we really identify these kind of skin changes and have to be intimated to the surgeon. I really thank you, sir, for your suggestion. Thank you so much, sir. And OT nurse, I acknowledge that we are also, and myself, I'm an OT nurse, and I'm really thankful to you for that suggestion. And I really acknowledge and appreciate that OT nurses have definitely a role in identifying the skin changes and intimating the surgeon, and have a role in post-operative infection prevention and healing process. Thank you, sir. Thank you so much, sir.
So how much is the infection rate in the country in this surgery? So that India is a very humid country, right? The weather is humid.
Yeah, but we have ICUs and OTs with a proper temperature control mechanism. So in our ICUs and operating room, we are having that standard temperature and humid conditions. So thereby, infection rates are much lesser.
Oh, okay. Thank you. So, Ms. Liu Miao, can you give any comment?
I guess.
Can you give any comment on the infection and post-surgical infection and and the wound management?
Thank you, inviting me.
Okay. Okay, thank you.
Well, I have a comment. You probably
Yeah.
didn't notice that in one of Liu Miao's presentation, she mentioned one of the good toy we can use in the postoperative pain patient is the WeChat group. Because in China, we use WeChat a lot. So we have a ependymoma WeChat group. So the patient can talk with other patients who already healed, went home, and ask for their opinion about the symptom, blah, 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 blah. And sometimes the patient may not trust the physician 100%, but he will trust a fellow patient. I think it's very important. We have a ependymoma WeChat group. We have a neurofibromatosis WeChat group. So let the patient communicate with each other will dissolve a lot of their doubt and their questions. I think I'm sure in Japan and in Malaysia you have other social network apps that you can use for this purposes.
Okay, thank you.
If I miss something, Nishimura Sensei.
Oh, yes, yes, please.
Thank you very much. All the presentations were very excellent and we learned a lot. Because you are doing mostly MIS surgeries, but it is the open surgeries also as equal to MIS surgery. The antisepsis required during the whole surgery is paramount for nurses who are assisting us. So where I do surgeries, usually there are disc tubular discectomies. So we have usually exposure, instrumentation, closure. So at every step we change our gloves. The entire team changes the gloves thrice. So that is one of the most important things that I have noticed, which keeps infection to a minimal as possible. That is
Yeah.
what.
Yeah, I agree with that. We always change the gloves and to interoperatively repeatedly and many times. Yeah, to prevent infection. That's very good, important point. Yeah, thank you. Okay, thank you for your making time to join this webinar, and I really enjoy the good discussion and the beautiful presentation. Thank you very much. So I want to close
Thank you
the
very
second
much. Now, can I call upon Professor Yamamoto to comment on the two nurses after the presentation? Can you give your comment, please?
Okay. Thank you for giving me the nice present. I'm very interested in very interesting nurses. I thank you for observing so much in area the doctor might not have noticed. So after all, we couldn't perform surgery without the nurses. Thank you so much for all your careful observation. Thank you.
Professor Igor, can you give your comment on the two nurses' presentation?
Thank you, Mei-Chun-Yi. And it's my honor to have this opportunity to attend this meeting. And the two nurses, the presentation are very good. And I have a comment for the Professor James Wang's question is how to identify the CSF to do what kind of testing. And I noticed Mr. Danya's presentation. It mentioned to test sodium to identify if it is a CSF, but usually we test like a glucose testing or more sensitive the beta-2 transferrin. And but for the spine surgery, if the dressing is wet, usually it is the CSF leak and no need to do more testing. And also for the mesothelioma case is giant tumors extending to more than 13 vertebral segments. And these cases are very rare. So these cases are very challenging, not only for neurosurgeons, but also for neuronurses. The peri-operative nursing is crucial for the patient's recovery. And also the interprofessional team collaboration is important for the comprehensive management of the patients of such giant intramedullary spinal cord tumors. So like the neurosurgeons, the scrub nurses, the healthcare professionals, the neuronurses, and the physical and occupational therapists, and the rehabilitation doctors. So also another point is in the literature, some researchers found the tumor length was not correlated with preoperative neurological status. I think that this is another point for the intramedullary spinal cord tumors. And that's all I want to say. Thank you very much.
Thank you, Prof. Ghoi. There was actually a question addressed to Prof. Yamamoto from Simon, but unfortunately he was disconnected. Prof. Yamamoto, he wants to know whether the best position for patient with CSF leak after minimally invasive surgery. Prof. Yamamoto, the best position for patient with CSF leak.
Maybe the bed rest is the best, but so bed rest. I think we need prone position.
Prone.
Just bed rest.
Okay.
No.
Okay. I think if there is no other further question, we should end this webinar. And thank you very much, everyone, for very informative lectures and discussion. So we shall meet again in the next webinar. Thank you very much. Bye-bye.
Bye-bye.
Thank you. Bye-bye.
Thank you. Thank you so much. Thank you so much. Bye-bye.
Thank you so much and
Dr.
bye.
Barnes, thank you very much. So you
あ
can
りがとうございます。
はい、どうもありがとうございます。More attend our the webinar, please. 山本先生、ありがとうございました。西村先生もありがとうございました。お疲れ様でした。